In this series, and exclusive to this channel, you'll hear a word-for-word account of what the jury were told after hearing 9 months of evidence during Lucy Letby's original trial. Now, with so much harmful misinformation currently being spread online and in mainstream publications surrounding this case, this series seeks to provide for the first time exactly what transpired in court. That means no ill-informed commentary or any bias, simply the evidence as presented during the trial itself. This video has been made possible by the purchasing of court-approved transcripts, further details of which can be found in the video description box below. What you'll hear next is a detailed summary of the prosecution's case against Lucy Letby. This took place at Manchester Crown Court and was conducted by Nicholas Johnson, KC. I'm going to move on to the cases of the children O, P and R. When I've said what I have to say about them, I'll then go back to the beginning to child A and deal with the babies that we haven't dealt with so far. So that's the midterm forecast. The reason I want to deal with the children O, P and R, and in particular with child O at this stage, is because of the uncontroverted evidence of Dr. Manorudis, the pathologist. I will come to the reasons why we say that Lucy Letby accepts his evidence in a few moments. But if, like her, as we suggest she has, you accept what Dr. Manorudis said about child O, then you can be sure that he was murdered. The only question then would be, who was the murderer? Somebody inflicted a really serious injury to child O's liver, didn't they? The likes of which Dr. Manorudis said you only see in road traffic accidents, bicycle accidents, or trampoline accidents. That was a really graphic way of him describing for all our benefits the sort of impact that is required to inflict that sort of injury. You've got the pictures if you really need to look at them, but I'm sure you all remember them without having to look at them, the full thickness bleeding right through the substance of child O's liver. That injury, together with the lacerations, do you remember Dr. Manorudis talking about lacerations in the surface, and he showed us on the photographs? That full thickness bleeding together with the lacerations in the surface of the liver. They are the best evidence you could ever have, really, we suggest, of someone having inflicted a forceful, violent injury on a very, very small child. I want to start with Lucy Letby's letter or note to the family of child O, P and R. This is your Exhibit 11, if we can put it on the screen. This is classic reading between the lines, isn't it, ladies and gentlemen? What we suggest, if you want, you can look at this yourselves in due course, but we suggest that it's obvious that this blank post-it note started off as a blank post-it note, but then with a note that Lucy Letby wrote to those 3 boys. Then she filled in the gaps with all sorts of other things. But the note reads as follows. To child O, P and R. Today is your birthday, but you aren't here, and I'm so sorry for that. I'm sorry that you couldn't have the chance at life you should have, and for that pain that your parents must experience every day. We tried our best, and it wasn't enough. I don't know if many people will think of you today, or any day, but I do. And I hope, and perhaps it says I will, and I hope I will always remember, because you should be. I can't do this anymore. I want someone to help me, but they can't. So what's the point in asking? Hate my life. End quote. So that's what started off, we suggest, on this piece of paper. Because adding that note into jumbled writing that was already on the paper, we suggest, isn't a sensible suggestion. That was written on their birthday. Obviously, it wasn't written while she was in Ibiza, so it has to have been written, and from the context, therefore it has to have been written mid-June 2017 or mid-June 2018. But interestingly, it came from her handbag, so it's something that she had kept. Lucy Letby had been in Ibiza and got back shortly after the birth of child O, P and R. And the text messaging shows us that she was very excited at the prospect of seeing them. Unfortunately for them, her objective was going to be to kill at least 2 of them. And on Wednesday, the 22nd of June, which is tile 24 in the child O sequence, She said she'd, quote, be back in with a bang. And within 72 hours of that text, 2 of the babies, OP and R, were dead. And she had tried, we say, to kill child Q. Dr. Gibbs, you will remember, when he gave evidence about child OP and R, was challenged on what he did about his concerns about Lucy Letby. It was suggested to Dr. Gibbs that if his concerns had been genuine concerns, he would have reported them to the police. But he said more than once, you will remember, that he never actually saw Lucy Letby do anything untoward, and if he had done, he would have gone to the police. Can you imagine, ladies and gentlemen, going to report your suspicions to the police in these circumstances? The first question would be, well, what have you seen actually happen? He's an intelligent man, he knows that question would be asked, and he's not prepared to make stuff up, is he? It tells you quite a lot about Dr. Gibbs. He also said, did Dr. Gibbs, that he was genuinely concerned and that the appropriate way of escalating those concerns within the hospital was followed. And in answer to a direct question in cross-examination when he was challenged about this, Dr. Gibbs said this. The death of the 2 children, O and P, was the tipping point for realising that something very abnormal and wrong was happening on our neonatal unit. And he was pressed again on the fact that he hadn't reported things to the police. Do you remember what his reply was to that? This in some way explains our approach to this address to you. His reply to that was, well, at that stage I didn't know that 2 children had been poisoned with insulin. It's really important that, ladies and gentlemen. But he was pressed further in cross-examination, and he said this. At a time of events that I have never seen in my career before, they were unusual and unexpected. As I keep saying, it was those events that worried us most. That's what raised the concern. Then in medicine, it's not an exact science. You can't always explain everything, which is highly unsatisfactory. So yes, just occasionally a patient dies, and despite extensive investigations and even a post-mortem, you can't be sure what's happened. But this was happening again and again on our unit over that year. And that cannot be just coincidence or just bad luck. There must be a cause. And that's when we began to realise who was involved with these babies, looking at each nurse, each doctor, and then there was one common cause that was identified. Ladies and gentlemen, the great advantage you have is you know that 2 children were poisoned with insulin. You know who was involved in hanging the bags. You know that that same person falsified the records in many of these cases. These are all things that were not apparent at the time. The mother of babies OP and R's evidence was the first that you heard relating to her sons. As I said, they were born on Midsummer's Day, the 21st of June 2016, so 7 years ago tomorrow. All were good weights, they were 33 weeks and 3 days gestation, they went into nursery 1 and all went well at the birth. And the following day, the 22nd, all went well that day as well. What the mother told you in her agreed statement was confirmed by other witnesses, including Dr. D and Kate Bissell. But things deteriorated for child O on the 23rd of June, which was the first day back from Lucy Letby's holiday in Ibiza. And that, ladies and gentlemen, is no innocent coincidence, is it? Overnight on the 21st to the 22nd of June, Amy Davies, in agreed evidence, told you there were no concerns for child O or child P. On the day shift of the 22nd, Samantha O'Brien, again in an agreed statement, said that child O was fine. Yvonne Farmer looked after child P in nursery 2, and during the day child O was moved into nursery 2 with his brother. Overnight, on the 22nd to the 23rd of June, just to remind you, when we asked Lucy Letby about her alleged shortcomings in the case of child O's case, she suggested that there had been an issue with the adequacy of dealing with the concerns raised by Sophie Ellis overnight. So that was the allegation by, or the suggestion by Lucy Letby. Well, what's the evidence of that? The shift leader Caroline Oakley told us that child O had done well during the day shift and was clinically well overnight. Both he and child P went from CPAP down to Optiflow. You'll remember that Chris Booth put it very nicely. He said that he thought that child O would sail through. Do you remember him saying that? With no problems. Sophie Ellis looked after child P and child O, and she's now a very experienced nurse and was looking back at events with the benefit of her experienced eye. She told us that overnight child O was, quote, very stable and there was nothing concerning. Very stable and nothing concerning. Put that against the alleged inadequacy of dealing with the concerns raised by Sophie Ellis. Lucy Letby is trying to persuade you. She's doing what she did on the ward, ladies and gentlemen, trying to persuade you that a problem existed where none existed. You will find, I'm not asking you to look at them, his observations at J23658. They are all very good. He had his ECG leads removed because he didn't need them, and his antibiotics had been stopped. And the fact that child O had had no infection is demonstrated by the results that were pending at that stage. If you want confirmation of that, all you need to do is look at tile 175 in the child O sequence. You remember, as always, they take 5 days to come back. After he died, it was confirmed that there was no problem. There you see it, quote, no bacterial growth after 5 days intubation. Sophie Ellis told us that she was getting back under half of the feed as a partially digested aspirate, which, according to her, showed he was tolerating the feed. His blood gases were good. Sophie Ellis said that the increase in the donor-expressed breast milk was standard, and there were no signs that child O was not tolerating it. And at the end of the shift, she had child O reviewed by Dr. Maybury because he had quite a full abdomen. Dr. Maybury remembered child O. Do you remember him being challenged about that in cross-examination? The gist of the cross-examination was, given that you didn't make a note, how could you possibly remember this child? And you'll remember his answer, won't you, ladies and gentlemen? That came out in re-examination. He'd never come across naturally conceived triplets before. It's not quite in the category of a medical marvel, perhaps, but something highly unusual that you would remember. And he did remember. Dr. Maybury told us that child O was very well, those were his words, and that his abdomen was, quote, mildly distended with no other concerning features. His observations were within normal limits. So what are these concerns? You remember the very short list, won't you, of the alleged shortcomings that was actually given by Lucy Letby when she was put on the spot in each case. This one isn't actually an issue at all. Maybe that's why she was so reticent in actually giving you anything to suggest that there was a motive for any of the Gang of Four to be conspiring to cover up their shortcomings. You'll remember, I'm sure, that Dr. Maybury didn't actually make a note himself about this examination, because he was emergency bleep for another child and asked Sophie Ellis to note the fact that child O's abdomen was soft. And you'll remember that when I was asking her questions, Lucy Letby pointed out the fact that Dr. Maybury had not made a note himself. And she took the opportunity to remind me that when there had been no doctor's note corresponding to a nursing note for which she had been responsible, I had suggested that she, Lucy Letby, had made up the nursing note. You'll remember Dr. B with child I on September 30th. Well, ladies and gentlemen, so there's no doubt about this, we absolutely stick to the suggestion we made to Lucy Letby. There are 2 occasions in particular where we say she invented things relating to doctors. The first was a supposed contact with the SHO or Dr. Wood in the case of child E, and the second, as I've just said, the imaginary examination by Dr. Beebe of child I on September 30th. Dr. Maybury said that had he found anything concerning, first of all he would have acted on it, and secondly he would have returned later to have made a note. When he was asked about blood in child O's peritoneum, this is the blood found later in the abdominal cavity at the post-mortem, He told us that if that had existed when he examined Child O at the end of the night shift, it would not have been consistent with Child O's presentation. In other words, he gave him a physical examination, and the way Child O reacted to the examination was not consistent with him having the bleed at that stage. And by that, we say that you can safely exclude as a reasonable possibility that Child O had the subcapsular hematoma in his liver at that stage. Dr. Mabry said Child O would clearly have been in discomfort and that was a very rare finding in a child of this age. And you can see Sophie Ellis' note is consistent with that being the position. No real problem with Child O. The following day, when Sophie Ellis arrived for her shift, do you remember who met her in the corridor to tell her the news about Child O having died? The day shift of June 23rd. This was student Rebecca Morgan's first shift. She was attached to Lucy Letby and student nurse Morgan fed Child O at 8:30. She got a trace aspirate. The shift leader for the shift was Melanie Taylor. She said there were no concerns as to Child O's stability at the start of the shift, and she also confirmed that the staff were generally twitchy about getting babies' tummies reviewed. That's important, isn't it? If there's a problem with the tummies, they would get the doctors to review. She also told us that shift handover sheets go in the confidential waste. She did not expect Child O to collapse. On the morning ward round, Dr. Cook at 9:30 examined Child O and Child P, having taken the handover from Dr. Mabry. She said that if any concerns had been raised by Dr. Mabry, she would have noted them at the time before doing the ward round. She did make a note, and Lucy Letby, or the designated nurse as Dr. Cook described her, told Dr. Cook there were no concerns. So much for failing to deal with concerns raised by Sophie Ellis. Direct evidence from Dr. Cook. Lucy Letby told her there were no concerns. Part of Dr. Cook's notes were, quote, trace of aspirates, none bilious. That's what she wrote in the medical notes. Dr. Cook upped Child O's feeds in accordance with the protocol, which is what Dr. Breary confirmed for you. And Dr. Cook said that this was a normal examination, which included Child O's abdomen. There was absolutely nothing abnormal, and she had no concerns. She described his clinical course as, quote, uncomplicated, and said he was making good progress. She excluded the possibility of there having been liver hematomas at that time. If one had been present, she said, and had been an acute concern, Child O's observations would have suggested a deterioration, and she would have had concerns expressed from the nursing team. In other words, from Lucy Letby. But when I was questioning her, I asked Lucy Letby about this examination, and the questions and answers went as follows. I asked Lucy Letby, do you accept that at 9:30 Dr. Cook examined Child O and actually felt the liver area and excluded there being an injury at that point? Lucy replied, yes. I then asked, so does it therefore follow that the liver injury Child O did sustain happened in effect on your watch? Lucy replied, yes. I then asked, do you accept therefore that somebody must have inflicted that liver injury on Child O during the day shift? Lucy replied, I agree that it's happened during that shift. I don't know how it's happened. I then said, well, we heard expert evidence from Dr. Marna Reeders about how these things happen, haven't we? And Lucy replied, yes. I then said, your case is you don't know how it's happened, and I assume you will say that you deny that it happened at your hand. And Lucy replied, that's right. I then said, do you accept the evidence of Dr. Marna Reeders? And Lucy replied, yes. So, ladies and gentlemen, that is why we suggest you can be sure that Child O sustained his liver injury while Lucy Letby was looking after him. It's notable, we say, that morning she was clearly missing Dr. A. She'd been in a text conversation with him until just before midnight the previous day. And if we go to tile 123, we can see that she was upset that he was in a clinic. At tile 127, she was asking whether he would be on the neonatal unit this afternoon. At tile 137, she said, quote, bit rubbish that you couldn't stay on the NNU. And he replied that he was in a clinic. At tile 158, at 10:36, he told her that he'd be finished in an hour. and Dr. A appeared on the NNU to see child Q, ironically, at 12:10. You will see that in the neonatal review at lines 35 and 36. We can see going back that at tile 165 he saw child O, and when Lucy Letby fed child O at 12:30, Lucy Letby recorded no problems. He was given 13 ml of donor-expressed breast milk, or at least that's what she recorded. You'll understand why I say that. We say that it's obvious from what followed that Lucy Letby deliberately overfed child O, and when you put this event into the context of what had gone before in the chronology with other children, like child G, we suggest you can be sure that is what she did. There was an issue at 13:15. Tile 168, please. Dr. A arrived to deal with a problem with child O, this child who had been fed supposedly only 13 ml of milk just 45 minutes earlier. By this stage, he had vomited and his abdomen was distended. We say frankly, ladies and gentlemen, Lucy Letby was fulfilling two objectives here. First, she was sabotaging child O, but second, she was also attracting the attention of Dr. A. At tile 169, Lucy Letby recorded in the nursing note that child O was tachycardic, and that was an exaggeration. She also recorded in the note that he had vomited undigested milk, but he had not been fed, according to the records, since 12:30. And previous to that, there had been no real problems, had there? In this context, ladies and gentlemen, it's interesting to remember what Samantha O'Brien said in her agreed statement. She said that although Lucy Letby had asked for Dr. A to review child O, she said this: "Other than his stomach appearing slightly distended, there was nothing else visibly apparent to me." And yet Lucy Letby was telling Nurse E much later in the day at 21:15 that child O had, quote, "blew up abdomen." You'll remember the similar message she sent to Sophie Ellis in child P's case the following evening. Dr. A, just going back to the 13:15 examination, examined child O because he was asked to by Lucy Letby. He told you he'd been in nursery 3 and was told that child O had vomited, which he said was unusual. Perhaps unusual generally, but as you know from the cases of child C, child E vomited blood, child F, child G, child I and child L, perhaps not so uncommon in the context of this case. Dr. A said that he was not told when it was that child O had vomited, and his medical notes that we were looking at before at tile 168 at the same time record that his heart rate was elevated. It's 160 to 170. His sats in air were perfect, and his temperature was perfect at 36.8. If you go, ladies and gentlemen, to J23658, which you'll find in Jury Bundle 2 behind Divider 20, you'll see, oddly perhaps, that Lucy Letby didn't even bother plotting the normal temperature on child O's vital signs chart. Why do you think that is? A normal temperature. Why wouldn't you plot that? The answer, because you're trying to create the impression that here we have a child who has a problem. So anything that's normal doesn't fit the narrative, does it, ladies and gentlemen? More to the point, where do you think that she got the information from when Lucy Letby made her nursing note at the end of the shift, long after child O had died? She enters into the nursing note details about what was going on at this time. So where has that information come from, if she's not recorded it on the chart? What was Lucy Letby actually doing between the 12:30 feed and the 13:15 vomit? If you look in the neonatal review, you'll find no record of her having done anything. Now, Lucy Letby made another false record on another document at about this time. She timed it at 13:20, so that would be 5 minutes after Dr. A's examination, and you'll find it in the blood gas chart. It's tile 170 or J23667. I'm sure you'll all remember this one. Even by the standards of her misrecording information, this one is right up there. There she records that child O was moved from Optiflow to CPAP. That is a lie. Completely untrue. It's the one that was spotted by Dr. Bowen. Do you remember? But as an explanation for why a child is full of air, or a child's stomach and guts are full of air, it's a very good explanation, isn't it? And it's one that's been advanced to you on many occasions, or advanced to the witnesses on many occasions during cross-examination. If anyone ever reviewed this paperwork, they'd look at that and they'd think, well, perhaps that is an innocent explanation for why this particular child who died had been pumped up with air. You'll recall that we asked her about this when she was in the witness box, and Lucy Letby began by saying that she didn't know why she had written it. And then she said this: "He wasn't on the full CPAP machine. I can't say whether he was having CPAP via the Neopuff. I don't know." That was her answer. Well, what did Dr. A find? He found that Child O's abdomen was distended because Lucy Letby pumped him full of air. That's why she tells the lie in the document. The area around his umbilicus was normal. The liver, the kidneys and the spleen felt normal. And Child O's bowel sounds were normal. The blood gas suggested he was more acidotic than Dr. A was expecting to find, but he could define no cause. He prescribed second-line antibiotics and included a prescription of a saline bolus of 10 ml per kilo. Because Child O weighed 2 kilos, that makes 20 ml of saline. And Lucy Letby recorded the giving of that in the nursing notes at tile 196, and it was signed for by Melanie Taylor and Samantha O'Brien within a couple of minutes. And within a couple of minutes, Child O collapsed. Before Child O collapsed, Melanie Taylor had looked at him and thought that he didn't look as well as he had. And you remember this bit of evidence, don't you, ladies and gentlemen? What she didn't know, what you know from all the circumstances, is that Child O by this stage had an internal bleed. We know that Melanie Taylor was in nursery 2 because that information appears at line 57 of the neonatal review. Melanie Taylor was the shift leader, and she said to Lucy Letby, "I don't think he looks as well as he did before." And Melanie Taylor queried whether Child O should be moved into nursery 1. You remember what Lucy Letby said, don't you? She said no. She wanted to keep him with his brother. Lucy Letby was so insistent that Melanie Taylor felt quite put out, as if according to Melanie Taylor, Lucy Letby was undermining her. Well, Melanie Taylor deferred to Lucy Letby because Lucy Letby had been looking after Child O all day. But you all know, and you can take into account, that if Child O had been moved to nursery 1, there were senior nurses in there, and Lucy Letby's other 2 babies were in nursery 2. And there would therefore have been a real risk, wouldn't there, that if Child O had been moved, Lucy Letby wouldn't have got the opportunity to carry through her plans for Child O. So that's the reason why she was against Melanie Taylor's suggestion that Child O should be moved to nursery 1. In the time between the desaturation of Child O at 13:15 and the beginning of his terminal collapse, we know that Dr. A had left the neonatal unit because he and Lucy Letby were exchanging Facebook messages. First at 2:08, then 14:20 to 14:29, and finally 14:37. 3 minutes later, at tile 199, Dr. A's note records that Child O desaturated. He was mottled. He was transferred to nursery 1. Lucy Letby and Samantha O'Brien then set up an infusion, which is tile 200. Just go to 200, please. This was a time when Lucy Letby recorded that Child O was not only, quote, mottled plus, but also had a red and distended abdomen. And there appeared to have been no doctors around when Child O collapsed at 14:40. So Lucy Letby therefore had her opportunity to sabotage him. So that's the point about the absence, as denoted by or as revealed by the text messages of Dr. A. Melanie Taylor arrived soon after Child O's collapse at 14:40. She then moved Child O with Dr. A. Dr. A told us that when he had arrived, the student and Lucy Letby were there. Child O had a low heart rate. He had desaturated. He was mottled. He needed continued breathing support in 100% oxygen as he was being transferred with SATs of only 50 to 60%. And Dr. A said that this was a prelude to a full cardiac arrest if it had been left untreated. That's what he described as a peri-arrest event. Dr. A drugged and successfully intubated child O, and he recorded that as having happened between 15:03 and 15:08. He then left the unit to speak to child O's parents on the postnatal ward. This is a recurring pattern, isn't it, ladies and gentlemen? Doctor leaves and you know what will happen. The X-ray that was taken just before the intubation, if we can go to TAL 197 please, Professor Arthurs told us about this. He said it showed a level of gas in the bowel, quote, which was more than would be expected in a normal baby. And as an explanation for how that could have got there, Professor Arthurs said it was either NEC, well we know from the evidence of Dr. Mana Reedis that it was not NEC, or someone had injected air down the nasogastric tube. Looking at the time of that, ladies and gentlemen, it's just before the intubation, I think. You'll take into account that at 13:15, so before this, child O had vomited. So that would have decompressed quite significantly, wouldn't it? The stomach. So this is even after a vomit. Dr. Breary had been in a meeting in the unit that morning. He spoke to Dr. A, who'd just moved child O from room 2 to room 1. Dr. Breary confirmed that there was good IV access because dopamine, one of the inotropes, was given at a later stage, and he offered to help Dr. A intubate child O. The mild metabolic acidosis, as it was described, indicated a non-respiratory problem. So this wasn't a breathing problem apparently. One cause or one potential cause that Dr. Breary gave for a mild metabolic acidosis was blood loss. So in other words, the blood gas at this stage of the intubation, is consistent with blood loss. And given what you know that they didn't know, you can put those pieces of information together. And we suggest this all tells you, doesn't it, that injury to child O's liver had been inflicted by about this stage. During the intubation, Dr. Breary noticed an unusual small rash on child O's chest. He said he looked like something normally associated with meningitis, a purpuric rash, which is very, very rare in a neonate. And it perplexed him because it was associated with good perfusion. He was pink. Dr. Breary thought, therefore, perhaps it was sepsis that was causing the problem. And you'll remember that text I showed you earlier that Lucy Letby sent later in the evening. But we can exclude sepsis, ladies and gentlemen, from the blood test results at TAL 175. So that wasn't the problem. They didn't know all this at the time, but you know that wasn't the problem. We heard about a meeting between Dr. B and Dr. A on the stairway. Do you remember that? This is when Dr. A had left to go and speak to the parents. They were together with Dr. B and Dr. A on the stairs at 15:49 when the bleep went off. So this must have been after Dr. A had spoken to child O's parents following the intubation. TAL 217 shows that Dr. A entered the NNU, we say, with Dr. B and Dr. A together entered the NNU at 15:53. What they saw, according to Dr. B, was child O being bagged by the nurse. His SATs were very low. He looked very unwell. Dr. B couldn't remember who the nurse was, but said that she would have taken the history from the nurse. Dr. B was shocked by what she saw. Child O's collapse was completely unexpected. The day before, he'd been fine. You will find that in notes at TAL 218. Both Dr. B and Dr. A confirmed that there was good air entry, but child O's SATs were not improving. And this is a thing we see time and time again, isn't it, with these children? Air going in and coming out, but the SATs not improving. Child O was reintubated, but his heart rate continued to be low. He was desaturating. He was given a second cannulation by Dr. B via a vein in his leg, which you'll find at TAL 217. And Dr. B, do you remember her explaining to us why that was? So they had 2 points of access just in case one of them failed. And you'll bear this in mind in the light of the false datics, which we'll come to. While that was unfolding, Dr. Breary was recalled at 16:30 to help Dr. B and Dr. A. Child O had been resuscitated. He had received by that stage 2 boluses of adrenaline and CPR. and by the time Dr. Breary appeared, child O's heart rate was back up to 140. His saturations were in the 90s, and spontaneous circulation had been re-established. Another miraculous recovery, ladies and gentlemen. A fingerprint of some of these attacks. But the ventilatory support had to be increased, and child O's perfusion was not as good as it had been earlier. The rash that Dr. Breary had seen earlier had disappeared, something he, Dr. Breary, had never seen before or since, and which he described in his understated way as perplexing. Well, you know what the reason is, don't you, given everything you know, everything you've heard about all these children? Dr. B said that this series of collapses was something she had never seen before. An experienced consultant, quote, "I've never seen this sort of thing before. It seemed like whatever we gave him was having no effect." The mother of babies O, P and R described her son arresting, and one of the significant elements of her harrowing account was the way child O was changing colour, with discoloration and prominent veins, which she said she saw the next day on child P. Child O's dad, the father of babies O, P and R, gave that video recorded interview, part of which you saw. And we suggest it was very important evidence in this case, not only in child O's case, but in the case in general. What he said was this. He could see all his veins, bright blue, going different colours. It looked like he had prickly heat. You could see something oozing through his veins. Oozing, that's movement, isn't it, ladies and gentlemen? It's agreed evidence, different colours and movement. As with many other cases, the parents of child O, P and R had just visited their son at the time of the fatal collapse. They were called back as a matter of urgency. You'll remember what I reminded you of about child L and M yesterday, what we will see again with the parents of child H, and what was to happen with them the very next day with child P. These are the circumstances, ladies and gentlemen. This isn't second-class evidence, is it? It's really compelling evidence of what was going on. The father of child O, P and R described child O's stomach as being like ET's. Some of the younger ones amongst you may have to ask the older ones exactly what that is. Most, if not all of you, know exactly what that means. Child O deteriorated and he was baptised. He required further CPR. He was one of the babies who had good gas going in and out, but failed to recover. Part of the resuscitation involved Dr. Breary seeking to decompress the abdomen by using a cannula needle at McBurney's point. It was obvious where the cross-examination was going, wasn't it? Because it was suggested that in some way had caused the liver injury. Do you remember? But you will remember also, I'm sure, first of all, the fact that Dr. Breary rejected that as a possibility. Well, the defence might say, well, he would say that, wouldn't he? If he caused the injury, he would deny it. But it's not just Dr. Breary. It's Dr. Marnarides and his very compelling evidence that a perforation from a needle could not, cause the liver injuries that were photographed at the post-mortem. There was no response to a resus that lasted for more than half an hour. The blood gas proved that there was not a respiratory cause. It was not a breathing issue that caused the collapse. The hemoglobin was down, but not so low that it would have been expected to have caused the collapse that was witnessed. Child O died at 17:47. At 20:09 that same evening, an X-ray was taken of child P, and it's tile 173 of the sequence. Dr. Arthurs took us to that image on Friday the 17th of March, and he said this. You'll remember this is 2 hours or 2 hours and 20 minutes or so after child O's death. So this is child P. Professor Arthurs said this. The stomach is dilated. These are loops of small bowel, and then this is the large bowel, so going all the way down. So this is gas throughout the gut, very similar to the appearance of child O. This degree of gas is quite unusual in a baby like this. It doesn't show obstruction, it doesn't show NEC, and there is a nasogastric tube in situ. And I asked him, what are the potential causes? And he said this. I think they're the same causes that we described in child O. So infection, NEC, those sort of things can cause this. Well, you know he didn't have that. There are obstructions to the bowel that you can be born with. We know that neither child O nor child P suffered from those. So you are left with other causes such as administering air via a nasogastric tube. It wasn't CPAP, was it? But that's the explanation for why CPAP was written on the chart in that false entry. The deaths of child P and child O caused real concern for Dr. Breary. He said of the triplets that all were born in such good condition and had been following a healthy path to growing and hopefully going home. He described these events as, quote, exceptionally unusual. The rash he saw was something he had not seen before and he has not seen since. All natural causes were excluded so far as Dr. Breary was concerned, even with the benefit of all these years that have intervened. Dr. A said this. This was incredibly unusual and it was unexpected. The ward round that took place at 9:30 in the morning recorded a well baby. And as the afternoon progressed, child O's clinical condition deteriorated in a way that's indicative of sepsis. But we know it wasn't sepsis, and that is why Lucy Letby was saying what she was saying to her mate Nurse E later that evening. And it started with a lie at tile 339. Nurse E says, assume they all seem stable if had all three. Then Lucy Letby responded, yeah, we're all fine. This one's still on Optiflow. That part's true. But weaning and all fully fed. Then at tile 342, had big tummy overnight. There's the lie. For this read, I inherited a problem. Just ballooned after lunch and went from there. Well, child O went from there, ladies and gentlemen, because Lucy Letby took him there. Took him to his death. 2133. Tile 403, please. She was sowing the seeds. Do you remember me saying gaslighting yesterday? Here she is sowing the seeds for what she planned for child P. And you will bear in mind that this text at 2133 comes about an hour and a half after that X-ray I just showed you of child P. The one described by Professor Arthurs as showing, if you exclude all other eventualities which can be excluded, air down the NGT. There's another interesting text later that evening, ladies and gentlemen, which tells you what Lucy Letby means. And this will become relevant when she writes a plus after something. I'm sure you've got the point, but this is air plus 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 or whatever in the context of child G. We're going to come to this, albeit the events relating to child G happened before this, but this is one of the reasons that I have taken things in this order. From tile 411 onwards, so that's from 2138 hours, Lucy Letby was having a conversation with Dr. A in which they were thanking each other for the support they'd given each other. At tile 416, Dr. A wrote, I'm glad you could talk to me and I hope I helped. And she responded, didn't want you collapsing mid-resus. If we carry on, please. Yes, you did, plus plus. So 2 pluses for Dr. A for all his help. It gives you an idea, doesn't it, when we're looking at some of her other notes. This is somebody who we suggest you'll decide that she was very keen on, not just as a friend, and 2 pluses was the best he was going to get. Ironically, a week later, on June the 30th, if we go to tile 498, please, Lucy Letby submitted a Datix form, which is what I was talking to you about earlier. This Datix form did not accurately reflect what really happened. You can see the description there at the bottom. Quote, infant had a sudden acute collapse requiring resuscitation. Peripheral access lost. Intraosseous access required. Peripheral access was not lost. Do you remember Dr. B when things started to turn for the worse for child O? Dr. B had put a second line in child O's leg. Dr. Breary told you that this is a lie. This is untrue. He didn't say it's a lie. He said it's not correct. We say it's a lie. You can find it's a lie if you think that's the right finding. But it's important, ladies and gentlemen, because here Lucy Letby is trying to create the impression through the use of the Datix form that the intravenous access was lost. And if there was no intravenous access, what can't you do? You can't inject a child's circulation with air if there's no intravenous access, can you? So if people accept what she's written here, it would tend to support her case that this was not a case of air embolus. Now, that's something that the experts just can't factor into their considerations. It's not a matter for expert evidence, is it? It's a matter for you as a jury to look at this, decide whether it's important, and decide where it takes you. This is where you have the advantage over everybody else. You are entitled to say, this is a lie. She knew it was a lie. Why is she lying? And if the only sensible conclusion is to cover up something she's done, what does it cover up? If it covers up air embolus, you are entitled to say, we are sure this is air embolus. Dr. Evans identified 3 areas of concern. First, the vomiting at 13:15, then the subsequent distension of the gut, and finally the death in association with the rash that he had seen identified in Dr. Breary's notes. Do you remember? He was criticised. He was taken to task for changing his opinion over a period of writing several reports. That period, as it happened, coincided with him being fed more information about what had happened as the inquiry progressed. Well, imagine the opposite, ladies and gentlemen. Imagine an expert who, when he's given more information that is inconsistent with an opinion he's expressed, doesn't change his mind. That would be astonishing, wouldn't it? Yet here he's being criticised because he's given further information and he says, actually, that does change my mind. His first report had been in 2017, but it wasn't until 2019 that he was told that the rash that had been noted by Dr. Breary at 15:03 had disappeared, and the questioning was extended. We then established that in the medical notes there's no mention of the rash disappearing, and it was only in 2019 that Dr. Evans had been told about Dr. Breary's witness statement where he had said the rash disappeared. Well, these are all matters for you to decide. Is the defence criticism of Dr. Evans for changing his mind in the light of that information a justified criticism or not? If it's not, you might ask yourself, why is the criticism being made? Is it just to create the impression with you that Dr. Evans doesn't know what he's talking about? We suggest it would have been astonishing if Dr. Evans hadn't changed his mind, particularly when you look at how the father of child O, P and R and also how Lucy Letby herself described events. I'm not asking you to look now, but at page 6 of the child O interviews, she says she went into the nursery at 14:40. The monitor was alarming. At page 7, she says nobody else was there at the time, that child O was mottled all over with a red abdomen and a blotchy purple-red rash. At page 8, she said that you quite often see mottling, but not to that extent. So even Lucy Letby, in her police interviews, was suggesting there was something very strange about what was going on. Dr. Evans formed his view independently of either of those descriptions, but you may think, knowing what you know now, that both of those descriptions actually support what Dr. Evans said. And as Dr. Evans himself said in cross-examination, I did not have all the information at the beginning, and therefore inevitably one amends one's opinion as a result. We then had cross-examination about CPR. Do you remember that? Because the suggestion being made was that in some way CPR was responsible for child O's liver injury. This question or suggestion was made on behalf of Lucy Letby. Quote, I'm going to suggest that you well know chest compressions are performed just in the area or just below the sternum. Below the sternum, almost over the area where the liver is or very close to it. That's where they're performed, isn't it, Dr. Evans? Dr. Evans replied, I know exactly where it's performed, and I don't know any baby who was resuscitated by experienced people who either died and where the post-mortem showed liver trauma as we describe here. And I know of no case where babies were resuscitated successfully, where cardiac compression was required, but where subsequent investigation noted the liver hematoma as described here. Mr. Myers then said, what I just asked you, it was a simple question. I apologise for having to repeat it. Chest compressions on a baby are performed in the area over just below the sternum, around the sternum, or over and very close to where the liver is. That's why I asked you, are you going to answer that? Well, he had just answered it, hadn't he? But Dr. Evans replied, no, it's over the top of the sternum. You're pointing in the wrong direction. It's over here, and he indicated. And the liver is down here, and he indicated. Well, a few days later, you saw the National Guidance on CPR, and the National Guidance on CPR supported what Dr. Evans said. Not only that, but you also heard later the evidence of Dr. Manarides, which I will come to in a moment. On the 5th of April 2023, in the context of the post-indictment text messages, you heard evidence from Dr. A that CPR was performed correctly on child O and child P. And so CPR is not the cause. There's no reasonable possibility, is there, that CPR caused child O's liver injury. Dr. Bowen. Towards the end of her cross-examination, it was suggested to Dr. Bowen, quote, "We have no discoloration from any of the clinicians who are present that we can identify as linking it with the Lee and Tanswell description, do we?" It's not just doctors who have eyes, ladies and gentlemen, surprisingly. Sometimes parents who are watching their children dying in front of them are quite interested in what's going on. The father of child O, P and R's recorded account. What better description? It's not second-class evidence, is it? Dr. Bowen, of course, spotted that lying entry in the gas chart. I've already dealt with that. It was then suggested on behalf of Lucy Letby to Dr. Bowen that, quote, "You've just tried to use any bit of discoloration you can come across to support you with this, Dr. Bowen, haven't you?" Well, you'll be the judges of that, ladies and gentlemen. As Dr. Bowen said, by the time she was giving evidence to you, she was taking into account what the father of child O, P and R said. How he gesticulated with his hands, do you remember, on that video? This is what he said. You could see all his veins, bright blue, going different colours. Looked like he had prickly heat. You could see something oozing through his veins. What Dr. Bowen hadn't heard, ironically, at that point, but what Lucy Letby knew was coming when this was all being put to Dr. Bowen, was Lucy Letby's own description, that one at page 7. Quote, "Mottled all over, red abdomen, bluey purpley red rash. You've just tried to use any bit of discoloration you come across." That's the assertion being put on behalf of Lucy Letby, who herself gave that description. Is there an attempt being made to pull the wool over your eyes, ladies and gentlemen, by Lucy Letby, just as she managed with all her colleagues in the neonatal unit? Part of the attack in cross-examination on Dr. Bowen was the finding of Professor Arthurs. It was said to Dr. Bowen that Professor Arthurs, quote, "does not conclude that this was a case of air embolus," as if Professor Arthurs had given you an alternative conclusion or had ruled out air embolus. Well, nothing could be further from the truth, we suggest, because what Professor Arthurs actually said was that you need to look at the history of the child in question. Do you remember the air in child O's great vessels? You may have a mental image of the spine of these children lying prone and the bubbles of air above it. And the mental image you have in the case of child A, child D and child O may be a very similar one. And the reason is because the pictures we suggest are very similar, at least to the untrained eye. What Professor Arthurs was saying is you need to look at the history of the child in question. And he said that the air in child O's great vessels could have been there because of CPR, could be trauma, could be infection, or because someone had injected air into the circulation. So Professor Arthurs wasn't excluding air embolus by any means. But let's look at the alternatives. We know that child O did not have an infection. So that leaves CPR, trauma, or air embolus. Well, we know there was trauma because of the liver injury, don't we? So that doesn't really help Lucy Letby. That therefore leaves CPR. Well, ask yourselves, why did child O need CPR? Who inflicted the trauma? And we suggest that the answer here has to be that either this is a direct consequence of another injury inflicted by Lucy Letby, or it was an air embolus. And air embolus is the obvious answer. isn't it? Because of the moving rash, the moving discoloration. Professor Arthurs wasn't taking into account the evidence of the eyewitnesses, or of Lucy Letby, or of the fact that Lucy Letby made a false entry on the gash chart. He was just working from his images in his darkened room. He wasn't taking into account the fact that both Child A and Child D had similar imaging after their deaths, both cases in which there was also evidence of discoloration. Professor Arthurs told us that he'd looked at all the children in this case independently, and did not use the findings he'd reached in one case in interpreting the images in another. In other words, he was deliberately not doing what you can do. You are entitled to look at everything. And so with that in mind, we suggest that what he said bears a good deal of consideration. And he told you, didn't he? And I've reminded you of this before, so I won't do it in any great length. He told you that radiographic evidence of air embolus is very rare. And because the consequences of air embolus are so serious, the attention of the treating medics is directed to saving the child's life, rather than standing back and taking photographs or keeping a note of what it is they can see on the skin of a child. That's an obvious reason, isn't it, for why the father of child O, P and R saw it, but the medical professionals didn't. And so in relation to child O, we finally come to Dr. Marna-Reedes. I just want to give you, if I may, a few bullet points from Dr. Marna-Reedes. We suggest that his evidence is both compelling and uncontroverted. You will probably never forget the presentation he gave you or the findings from child O's liver. And of those liver injuries, he said this. Number 1. They were full thickness, right through the body of the liver. Number 2, they were an impact injury because there were lacerations on the outer surface of the liver, and therefore someone exerted significant force on the 2-kilogram child O. Number 3, this was certainly not an injury from CPR. And in this connection, he said that it was the position of the injuries and the force required to have caused the injuries which meant that CPR was not a viable cause. He had never seen, had never heard of, had never read of this type of an injury being caused by CPR. And given the number of children who have to be resuscitated at hospitals up and down the country, we suggest that the idea that this is the only time this sort of injury has resulted from CPR is truly fanciful. He also said finally that these were not injuries caused by Dr. Breary's attempts to decompress the abdomen, and the reasons he gave was that there was no corresponding puncture injury which could have caused the internal bleeding, and the location of the danger to the liver would have been impossible to cause with a needle. As for the mark on the outer surface of the liver on the photo, he told you that in all likelihood that was something that had occurred after death because there was no associated bleeding. He said that if that had been caused by Dr. Breary, then by that stage child O had no active circulation, so in reality, in effect, was already dead. Otherwise, he said there was profound gastric and intestinal distension. Putting it more bluntly, ladies and gentlemen, in the sort of language that I can understand, child O's stomach and bowels had been blown up with air. And his view, Dr. Marna-Reedes' view, was that the cause of child O's death was, quote, an inflicted traumatic injury to the liver, profound gastric and intestinal distension, following acute excessive injection of air via the NGT and air embolus. We say simply, ladies and gentlemen, that the murder of child O was cruel and it was violent. All of the offences on this indictment were appalling examples of attempts and completed murders. Some of the earlier offences were less overtly violent, but no less devastating. We say Lucy Letby used violence and air on child E. Unfortunately, there's no evidence from a post-mortem examination of what internal injuries caused him to bleed. But no doubt the fact that she had got away with so much by the time she returned from Ibiza, it gave Lucy Letby the misplaced confidence that she could pretty much do whatever she wanted. Her objective, as always, was to kill. In child O's case, she undoubtedly combined all of the three methods she had previously used to such devastating effect on the other children in this case. And in order to try and cover up what she did, she had falsified the notes. And we say, frankly, by this stage, she was completely out of control and was determined to mete out the same treatment to child P the very next day.